Hi, everyone. My name is Jean. I'm a dietitian and CNSC in the Chicago area and proud member of DNS. So today we're going to do a video on renal nutrition support, specifically enteral nutrition. We've actually received a lot of questions and requests for a video on this topic, and the timing actually ties in perfectly because the April edition of Support Line, which is published by DNS, is all about renal nutrition support. So we encourage all of you DNS members to check out this issue of Support Line, and we'll refer to it a couple times throughout this video. It's full of great information. So in this video specifically, though, we'll talk about the difference between an AKI or an acute kidney injury and CKD or chronic kidney disease, and how the nutrition support might differ in those cases. We'll talk through a couple of tube feeding case studies. So the first being a patient who is newly dependent on nutrition support, but has end-stage renal disease and has been on dialysis for some time. And our second case study will be a more critically ill patient who has no history of CKD, but who requires dialysis as a result of new renal failure from a severe AKI. And at the end, we'll talk a little bit about a topic that pretty much every intern that I've ever had and every student that I know of has been curious about, which is how to balance protein needs in particular for a patient who has end-stage kidney disease, but not yet dialysis dependent, so maybe a CKD4 or a CKD5, but who also has other conditions that might increase their protein needs. So how to balance those recommendations for lower protein with kidney failure, but higher protein with acute illness. First, we're going to talk about the definitions and terms that I'm going to refer to throughout this process, just so we're all on the same page here. So there are a lot of specific terms and definitions used in the medical world, but specifically in renal world. So we're going to start there. An AKI is an acute kidney injury, and there are three general types. There's pre-renal, meaning something's happening before the kidney itself that results in an injury to the kidney. There's a renal or intrinsic injury, meaning that something's happening directly on the kidney itself that causes the injury. And then there's post-renal, which means something is happening past the kidney, so with the urinary system, that results in an injury to the kidney. So pre-renal AKIs can be caused by really anything that reduces the amount of blood flow that's going through the kidneys. So kidneys like to be perfused. They really don't like it when they're not perfused. And anything that prevents that from happening can cause an AKI. So that might be hypovolemia from dehydration if someone is, having a lot of vomiting or diarrhea, or maybe they're just not, drinking adequate fluids. If they're bleeding, which would reduce their blood volume, or if they have cardiac arrest, which is, of course, reducing the amount of blood perfusing the kidneys. It could also be due to vasodilation, for example, from sepsis, or ineffective blood flow as a result of like a CHF exacerbation. Those can all cause pre-renal AKIs, among with a lot of other things that you can find a better list of those in that support line article. An intrinsic AKI can be due to a kidney infection, so pyelonephritis, rhabdomyolysis, contrast nephropathy, or often nephrotoxic meds. So the two that come to mind for me are vancomycin and NSAIDs, but there are a lot more than just that. Again, there's a more comprehensive list in the support line article. And then a post-renal AKI could occur from, prostatic hypertrophy, tumors, kidney stones, ureteral stones, anything that's kind of obstructing the urinary tract. So oftentimes, AKIs resolve with good treatment and the patient returns to their baseline kidney function, which could be normal, or it could already be stage 1 to 4 of chronic kidney disease. So in this case, the condition would be called AKI on CKD, because there's baseline CKD and then an acute injury occurring on top of that. Occasionally, an AKI can be so severe that the patient might need dialysis until their renal function recovers, or in some cases, it can cause enough damage to progress baseline CKD towards ESRD and actually end up with the patient being permanently dialysis dependent. So I think we all know what CKD is, just in general terms, and then once you get to CKD stage 5, you become classified as end-stage renal disease, and at that point you either need dialysis or a transplant.
The first patient we have today is named Mr. Lester. He is a 68-year-old male. He is 71 inches tall, 319 pounds, and that puts him at a BMI of 44.5. We know a little bit of past medical history about him. He has type 2 diabetes. He is also classified as having end-stage renal disease, and he's been on hemodialysis regularly for 3 times a week. The reason that we're seeing Lester today is he has recently been hospitalized following a cerebrovascular accident. You might also know this as a stroke. He's been NPO for 2 days since his admission, and he's expected to be hospitalized for 5 to 7 more days. After the completion of his hospitalization and his ability to heal a little bit in-house, he's planned to have discharged to an acute rehab facility. Things to know about him: he was recently dialyzed yesterday, and remember, he's been receiving dialysis because he's been on hemodialysis regularly for his ESRD. And because of this cerebrovascular accident, he had a G-tube placed on his admission. So we are now going to be making a plan for the nutrition support that we'll be providing through his G-tube. It's important for us to know that the reason the G-tube was placed is because there's an anticipation that he'll probably be needing nutrition support for at least 4 to 6 weeks due to the severity of this CV. So the first thing that we might do if we're going to be writing a tube feeding order for a dialysis patient is to look at their labs. So contrary to what your instincts might tell you, not every dialysis patient is going to need a renal-based formula. So regardless of brand, those renal formulas are typically restricted in volume, potassium, phosphorus, and are a little bit on the higher side in terms of calories and protein per liter compared to a standard formula. So Lester's labs indicate a lot of what we already know. We can see from our values here, it's fairly clear that he has end-stage renal disease, and we already knew he was dialysis dependent for that. He's a touch on the higher side of normal in terms of his sodium values. His potassium is borderline elevated at 5.2, and his phosphorus levels are elevated at 4.9. And we do already know that he was dialyzed yesterday, so there's no plan to dialyze him until his next session tomorrow.
Great. So now we come to the point of deciding whether or not we want to use a renal formula for our patient. So generally speaking, I'll use a renal formula if the patient has normal or high serum potassium, particularly on their non-dialysis days. My rationale here is that the patient will be going at least another 24 hours before their next dialysis session, if you're looking at labs from a non-dialysis day. And if they're anuric, they have no method of excreting the potassium that we introduce into their system. Thus, I think it's safest to choose a renal formula in these cases, as long as it's not contraindicated. So some renal formulas have fiber, and you may or may not be comfortable with using fiber-containing formulas if your patient is critically ill or in the ICU. For Lester, he's not critically ill. He's sick, but he's not critically ill. He is a chronic dialysis patient, and his potassium and phosphorus are both high already on his non-dialysis day. So for that reason, I'm going to choose a 1.8 calorie per milliliter renal formula for Lester.
Okay, so it sounds like a renal formula is going to be our best option for Lester. So now we just need to figure out what our starting goals are going to be for calories and protein. So when we're looking at energy intake recommendations for adults with CKD stages 1 through 5 who are metabolically stable, we typically see a recommendation for an energy intake of 25 to 35 kcals per kilogram of body weight. But this recommendation is going to differ significantly depending on the age, sex, level of physical activity, body composition, weight status goals, CKD stage, and other concurrent illness or presence of inflammation happening within our patient. As such, the recommendation for calorie intake is really going to be based more on clinical judgment and the specific patient's health goals, so all of this is going to be personalized to the patient. In Lester's case, he does have an obese BMI, so I'm going to recommend that we actually feed a calorie range somewhere within 15 to 18 kcals per kilogram of actual body weight. Again, this recommendation can vary widely, so it's all really going to be dependent on the specific patient that you are working with as to what kinds of energy guidelines you are going to be using. Utilizing 15 to 18 kcals per kilogram, that's going to put us in a range of 2175 to 2610 kcals per day. And because Lester's a hemodialysis patient, we want to, of course, ensure that we're getting him enough protein throughout the day. So I'm recommending that we use a 1.0 to 1.2 grams of protein per kilogram per day. And so that's going to put us in a range of 145 to 174 grams of protein per day. To give us some initial starting goals, I'm going to start at the low side of each of our calories and protein needs, and then adjustments can be made as we see how Lester tolerates this enteral nutrition plan, and then also as he transitions out of inpatient care and into his acute rehab care. So that's going to be a starting kcal goal of 2175 and a starting protein goal of 145 grams per day. So in order to make our enteral nutrition plan, we of course need to figure out how many total number of meals we're providing throughout the day, and we can utilize our number of kcals that we want to provide to get that information. If we want 2175 kcals per day over across 24 hours, we can use this information about our renal formula in that it has 1.8 kcals per milliliter to figure out how many milliliters we'll require to get to that 2175. And if you divide 2175 by 1.8, you will get 1208 mils per day. Now at this point, I like to identify what the rate is that we're going to be providing all of these milliliters. So of course, we're going to be providing this all throughout the day across 24 hours. So if we take our 1208 mils and we divide by 24 hours, that will get us approximately 50.33 mils per hour. Obviously, it's near impossible to provide a fraction of a mil per hour, so we don't really want to be dealing with these decimal points here. So I'm going to go ahead and round this to 50 mils per hour. So because there was some rounding, I of course want to double check how many calories I will be providing. So I'm going to multiply my 50 mils per hour times the 24 hours in a day. And that's going to give me 1200 mils per day. And if we take our 1200 mils per day and we multiply it by 1.8 kcals per mil, that'll get us a total number of 2160 kcals. So I know this is a little messy, but we got a lot of information here. We know that our rate is going to be 50 mils per hour. We know we're going to provide 1200 mils per day, and we know that's going to give us 2160 kcals. It's going to be a little bit easier for us to work in the units of liters for the remainder of our calculations. So let's go ahead and transition our 1200 mils over to liters. You probably already know that there are 1,000 milliliters in 1 liter, so if we just divide by 1,000, we will get 1.2 liters of formula throughout the day. So with our 1.2 liters of formula, we can then solve to see how many grams of protein we'll be providing from the formula alone. We know from up here that there's 81 grams of protein per liter, and that'll give us a total of 97.2 grams of protein. So in order to get us closer to our goal of 145 grams of protein per day, I'm going to recommend that we utilize some protein modulars. There's many different types and brands of protein modulars, but our basic composition that we're going to utilize for our calculations today is right up here. It's going to include 25 kcals and 6 grams of protein per packet. So we're going to imagine our protein modular comes in packets. So to understand how many packets of protein modular we're going to utilize, let's see how many grams of protein we still need to meet our goal. If we take our goal of 145 grams of protein and we subtract the 97 grams that we're providing from formula, that leaves us with a remaining need of 48 grams of protein. So we still need 48 grams. So if we need 48 grams of protein and each packet has 6 grams of protein in it, so one packet has 6 grams protein, we can utilize a little bit of stoichiometry here to see how many packets that's going to leave us with. So 48 divided by 6 is going to leave us at an equal 8 packets of protein. So if we're going to include 8 packets of protein, this means that our actual end provision of protein is going to be 97.2 plus 48 grams, which is going to leave us with a total intake of 145.2 grams of protein per day. So we've made it into our goal range. You'll notice that, of course, we can't provide protein without also providing kcals, so our protein modular is going to provide 25 kcals per packet. So let's add on here to our total number of kcals. We're going to be adding on 8 packets that are 25 calories each, which means we're going to end up adding on 200 additional calories, which leads our total calorie intake to be 2360 kcals per day. Now let's see what remaining macronutrients and free water our formula will provide. So if we have 1.2 liters of formula and it's not providing any carbohydrates within our protein modulars, we can just take our 1.2 liters of formula, multiply by the 160 grams of carbohydrate per liter of formula, and we'll get a total number of 192 grams of carbohydrate. Same thing with lipid. We can take our 1.2 liters. We know there's no lipid within our protein modular, so we just multiply by the 96 grams of lipid, and that gets us 115.2 grams of lipid. And we can take our 1.2 liters of formula and multiply it by the 727 milliliters of free water per liter. That gets us 872 mils of free water per day from the formula. It's important to note that protein modulars typically come as powders, so you're likely going to have to mix them with water for them to be provided to the patient. As our patient goals for fluid, specifically for a patient who is on hemodialysis, we're looking to be somewhere within the range of 1 liter of fluid plus urine output. And because we don't know the urine output for this patient, if we assume that he is not actually excreting any urine, we might want to steer towards more of the 1 liter range. But if there's any urine excretion, patients can have a little bit more fluid throughout the day. So it's good for us that we came below our 1 liter of free water provided from the formula, so that gives us a little bit extra room for, first off, our protein modulars to be able to be dissolved in water and then provided. And second, for any extra flushes that may be needed throughout the day, whether for passing medications, for starting or stopping a line, or to just provide extra fluid to the patient. So at this point, we've now identified Lester's overall rate, the total kcals he'll be provided from both formula and from protein modular packets. We've upped his protein to reach into that goal range, and we still have a little bit of extra room in terms of our free water to be able to provide that protein modular as well as some extra flushes as needed.
One thing to keep in mind on the topic of electrolytes in these patients is that there is still the potential for refeeding syndrome. And it can be masked in patients with end-stage renal disease on dialysis because they're not excreting electrolytes as effectively as someone with better kidney function. It's still important to be aware that it's possible for them to undergo refeeding, but not as likely. So refeeding syndrome in dialysis patients may not be as obvious though. For example, if we have a patient who's been, NPO for 6 or 7 days, and then we start them on nutrition support, and their phosphorus might drop from 7.2 to 3.9 over 24 hours. So we might see that level of 3.9 and think like, hey, that's a normal phosphorus level. We're fine to go ahead and advance the tube feeds. But what we have to take note of is that a drop from 7.2 to 3.9, if it happens, in the absence of phosphorus binders or dialysis, that's pretty significant. And if the phosphorus continues to drop at the same rate, the next day, they'll be pretty significantly hypophosphatemic. So while they're not necessarily as at risk for refeeding as non-dialysis patients, it is important to keep in mind that it can still happen, and it might be more easily missed because their labs might drop from high to normal instead of from normal to low.
All right, so our second patient today is named Phyllis. She is a 71-year-old female, a height of 5 feet 2 inches, a weight of 158 pounds or 71.8 kilos, and a BMI of 28.9. She was admitted to the hospital following a cardiac arrest. She did have return of spontaneous circulation, or ROSC, after 12 minutes of CPR and epinephrine provided to her. She is currently in the ICU and she is experiencing acute renal failure secondary to rhabdomyolysis and a lack of perfusion to the kidneys during the cardiac arrest. She's in need of tube feeding due to the fact that she's currently intubated. She's at 24 hours length of stay thus far, and the prognosis is unclear, so we don't know how long she will be intubated. We don't know how long she will be in the hospital setting, but we do know that she is ready to start enteral nutrition. In terms of the labs of interest, you can see here that we have a very high creatine kinase value, likely attributed to the fact that she just experienced cardiac arrest and CPR. And you can also see the signs of acute renal failure in terms of a very high serum creatinine and a high BUN value. We're also seeing a very low value for bicarbonate, which is indicating that she's very acidemic. We're also seeing a high phosphorus value, but we're seeing a normal potassium value. We were also able to read through the nephrology consult and see that they've actually placed a Quinton catheter and are planning to start dialysis due to the drastically decreased urine output despite diuresis. We're also seeing that severe acidosis and the uremia happening, so they're hoping that the placement of the catheter and some dialysis will be helpful for Phyllis to be able to have renal recovery. It is anticipated, as stated in the note, that she'll need dialysis, likely for at least a few weeks. Now, because Phyllis will be dialyzed during her time in the hospital based on the placement of the catheter, we know that she'll require a little bit higher caloric needs, so we're actually going to be aiming for somewhere between 30 to 35 kcals per kilogram, just as a ballpark, because we don't have information based on indirect calorimetry. So that puts her between 2154 and 2513 kcals per day. And we're also going to be trying to provide a higher amount of protein, again due to the fact that she'll be dialyzed, looking somewhere between 1.2 to 2 grams per kilo, which puts us at 86 to 144 grams per day. So hopefully utilizing this range of needs, we can satisfy all of Phyllis's needs based on the fact that she's number 1 on dialysis, number 2 just experienced cardiac arrest, and she's categorized as critically ill.
Okay, so in Phyllis's case, or in the case of really any nutrition support dialysis patient, there are some issues that we could run into that might change our nutrition plans. So in the case that Phyllis is receiving dialysis and maybe they're having trouble pulling enough volume off of her, so whether that's because her blood pressure doesn't tolerate it, or, it's just something's going on where they can't take off the amount of fluid that they hope to. We might want to reduce the total volume that we're providing to her from tube feeds and free water. So in this case, if the nutrition-related renal labs are still normal, so your potassium and your phosphorus are still okay, you might want to simply switch to a more concentrated standard or hydrolyzed formula so that you can more easily adjust the total volume by adding or removing free water. So in this case, I might switch from the high protein 1 calorie per milliliter formula to a 1.2 calorie per milliliter, or 1.5 even if you want to reduce the amount of volume even more. Another problem that might happen is that the renal function doesn't recover as they were hoping it might. So her labs might progress. She might end up hyperkalemic, hyperphosphatemic, and at that point, it could be time to transition to a renal formula. Usually in my personal practice, if I see that a patient is requiring, K-exolate or whatever variety of potassium reducing medications, if they're requiring that at least once or twice, I usually make the switch to a renal formula so that we can, hopefully reduce the amount of hyperkalemia that is happening.
So we're ready to start tube feedings with Phyllis, but there are a couple things about Phyllis's case compared to Lester's case that are a little bit different. So Phyllis is not anuric, she's oliguric as a result of severe AKI, but there's hope that she will be able to regain some of her kidney function. So this is going to change our fluid needs. We're not working with the assumption that her fluid needs are going to be 1 liter per day plus urine output, but instead we're actually going to maintain the baseline fluid needs for these AKI patients, and in this case Phyllis, until the labs kind of point towards something different, sort of a lack or a decreasing kidney function as opposed to a potentially increasing or improving kidney function. For Phyllis, she also has a normal serum potassium despite the very severe AKI. So for all of those reasons, we're opting to use that non-renal formula for her. So like we already mentioned, she's needing somewhere between 30 to 35 kcals per day, and here is that range. We're going for quite a high protein due to all the variety of factors Phyllis has going on, that 1.2 to 2. Putting us in this range, and as just discussed, it is most beneficial for patients who have AKI as opposed to a chronic kidney injury to actually maintain their fluid recommendations as per usual. So we're going to see those fluid recommendations actually being in a 1 ml per kcal range for her. So we're going to start with an initial goal for Phyllis of 2,200 kcals and 130 grams protein. If we're looking at that 2,200 kcals per day, and we know that this formula has 1 ml per kcal, that is pretty easy math for us to see that we're going to be providing 2,200 mils per day. And like we always do, we want to make sure that we can pick a rate that's going to be appropriate for her and then make calculations based specifically on that rate. So if we want to take our 2,200 mils across a 24-hour period, that's going to give us a rate of 91.7 mils per hour. And as we've already discussed, we don't really want to keep ourselves within any decimals or any strange values, so we're going to round down our recommendation to 90 mils per hour. And with 90 mils per hour times the 24 hours in a day, we're going to see that giving us 2160 mils per day. And because we know that 1 mil has 1 kcal, we also know that we're going to have 2160 kcals per day. So if we're using our 2160 mils, we can drop that right here and transition our milliliters over to liters, and we can just divide that by 1,000 to get 2.16 liters. Because this is the amount of liters that we have, we're going to drop that into our equation here. in which we can say that 2.16 liters times the amount of grams of protein per liter of formula, and that's going to give us 135 grams of protein per day. We can again bring that 2.16 down, really to fill in all of these blanks. And then we can just keep doing our multiplication across. So 2.16 times 26 is going to give us about 56 grams of lipid. And 2.16 times 130 grams of carbohydrate is going to give us 280.8 grams of carb. And so if we're going to give 2.16 liters of formula, and each liter is going to have 839 mils of free water, that's going to give us 1812 mils of free water per day. And as you already know, we're aiming to get our fluid range up towards about 1 mil per kcal provided, and so we're not quite getting there with just the fluid provisions from this formula, so we're going to want to be providing some additional free water flushes as well. So one approach to free water flushes could be the choice to do free water flushes maybe every 8 hours, and somewhere in the range of 150 mils each time would give us an additional 450 mils per day. And if we were to take our 812 plus our 450, that would get us somewhere close to 2262 mils of free water per day. So that would get us in range for our fluid recommendations. And as you probably know, there are quite a few different ways that you can approach free water flushes. So really, any kind of combination of providing flushes throughout the day that'll get you into the range of fluid provisions that we're aiming for is plenty satisfactory.
Finally, I wanted to touch on a topic that I alluded to earlier that I get a lot of questions on. I know I still have some questions on as well, and that is addressing protein needs in particular in patients who are CKD stage 4 or 5, so kind of towards the end, but not quite dialysis dependent. So that gives them lower protein needs. But if they're critically ill or they have other things going on that give them higher protein needs, how do we kind of balance those two conflicting situations? So looking at the Kudoki guidelines that came out, and these are referenced in the support line article on enteral nutrition from April, it tells us that protein needs for individuals with baseline chronic kidney disease stages 3 through 5 who are not on dialysis are 0.55 to 0.6 grams per kilo of actual body weight. If the patient also has diabetes, those recommendations increase to 0.6 to 0.8 grams per kilo of actual body weight. So the point of the lower protein is to reduce the risk of progressing the CKD to end-stage renal disease by reducing nitrogenous waste. Thus, you're reducing the filtration burden on the kidneys. However, we know that critically ill patients need, kind of ballpark anywhere from 1.2 to 2 grams per kilo of protein. So how do we balance the lower protein recommendations with the higher protein needs of a state like critical illness? So there are plenty of approaches here, and I think that as long as you have justification to back up your choice, you can make a variety of decisions. Personally, I try to aim for the middle ground. So usually around 1 to 1.2 grams per kilo if I have a patient who's around CKD stage 4 or 5, but they are also critically ill or have something else that's elevating their protein needs. I'll keep an eye on the labs and nephrology notes, as well as keep in mind why the patient has elevated protein needs. So for example, if they're critically ill and they have a stage 4 pressure ulcer, I would probably increase the protein more than just 1.2 grams per kilo. It's all about kind of prioritizing what you think you need to address first, and hopefully achieving kind of a balance where you're providing enough protein to where they're using everything that they need without providing excess protein to increase the stress on the kidneys. Okay, so I think we're going to wrap it up for our first renal nutrition support video. Please leave any questions in the comments and we'll answer them to the best of our abilities. Thank you for watching, and we'll see you in the next one.